Okay. Okay, continuing.
Yeah.
So 75-year-old male patient squeezes his chest and fall down. So what you should do? Clear the airway of the patient. Check the peripheral pulse. Chest compression should be done. Call for help. And the answer will be call for help. But at the same time, you have to start cardiopulmonary resuscitation also. So let's see what they are telling. In this case, a patient is unresponsive, that is no breathing. In this situation, two things can be done. One is CPR and another is defibrillator. Now, first option is manual option. You can do anywhere actually. Now, next option is more advanced option, and you need to have access to the defibrillator. For that, you need to be in an institution, in a hospital with defibrillator present. So here you have seen in the question, it is written that you were present at the scene. So we can consider that there is no defibrillator. Now we can always do CPR, but before that, manual option may not work and may not be effective. But CPR we can do, but CPR will not be sufficient for this case. As not like, as if we give CPR, it would be an improvement, but it cannot save. In the long run, it will not be effective. That's why it is recommended that you call for help, so that the ambulance can come and the patient can taken to the emergency department for using defibrillator. In the meantime, you start CPR. So CPR plus call for help, or we can say call for help plus CPR. First call for help and then you start CPR. And defibrillator will be used in the hospital when the patient will be taken to the emergency department. Okay, next question. A female patient of 42 years old develops recurrent episodes of sudden palpitation. Recurrent episodes of sudden palpitations. On examination, heart rate was found to be 150 per minute, but the rhythm is regular rhythm. Now, from the history, it can be found that after every episode, she has diuresis. What can be the possible diagnosis? So, what we find is, first of all, the female patient for 42 years, number one. Number two, recurrent episodes of sudden palpitation. Number three, heart rate was 150 per minute. Rhythm was regular. In every episode, she has diuresis. So what can be the possible diagnosis? Atrial fibrillation, PSVT. Sinus tachycardia, atrial flutter with block. And the answer is PSVT. So why PSVT? As the rhythm of the heartbeat is regular, it indicates atrial flutter or fibrillation is not present. This is the first thing we can get. Regular rhythm, that means no flutter or fibrillation. In flutter, there will be no P wave. In fact, there will be no atrial contraction. There will be only vibration of the atrial wall. So regular heartbeat, that means no flutter, no fibrillation. Sinus tachycardia. Sinus tachycardia is a kind of physiological response, and it is less likely. It's a physiological response. It is less likely to happen here. So by exclusion, we can see atrial fibrillation cannot happen. Atrial flutter cannot be the answer. Obviously not with block. And sinus tachycardia is a physiological response which has not occurred here because there is a condition. You can see episodes of sudden palpitations. Heart rate is found to be 150 per minute. Then in every episode she has diuresis. Only the rhythm is normal. Only the rhythm is regular rhythm. This is normal. Otherwise, there are other findings. So it should not. We cannot choose just sinus tachycardia, simply tachycardia. No, because we cannot ignore other features like sudden palpitation, diuresis. We cannot ignore all these findings. So we can by exclusion we can see it is PSVT. Now it is quite common in females, especially in the 2nd to 4th decades of life. Another fact that is favorable for PSVT, for the answer being the PSVT, is it occurs in 2nd to 4th decade of life, which is matching for this patient, and this condition can also be found in the absence of any structural abnormality of heart. Very important. PSVT first is second to 4th decade of life. It occurs. Number 2, absence of structural abnormality of heart. Elevated venous pressure leads to release of natriuretic peptides. Now venous pressure increases, leading to the release of natriuretic peptides, which can cause diuresis. Diuresis occurs due to natriuretic peptide as well. So these 3 favorable points are there, which can for which we can choose PSVT. Okay, and otherwise you by exclusion you see option A cannot occur, option C cannot occur, option D also cannot be. So B is the answer, PSVT. And these favorable points are this, not only by exclusion we are doing, but also there are some favorable points. Okay, so this is about PSVT. Now here we have we can see some arrhythmias, atrial fibrillations, atrial flutter, PSVT, ventricular tachycardia. So in PSVT, what happens? Mostly there is no underlying disease, as we just now discussed. Atrial rate is 132, 250, and here it was 150. So much within this range. Initial or retrograde P waves. Anyway, here ECG result is not given. Okay, so initial retrograde P wave should be can be found, and primarily carotid sinus massage is applied. As for the management, DOC can be adenosine. DOC is adenosine. For recurrent PSVT, radio frequency ablation. Radio frequency ablation can be the treatment of choice for recurrent cases, and drugs like beta blocker, CCP can be used to prevent recurrence of PSVT. Okay, so almost you see the underlying disease and this atrial rate also another favorable point. Atrial rate is another favorable point that we can get for this question. Okay, and other arrhythmias like atrial fibrillation, atrial flutter, ventricular tachycardia, all are summarized here, and torsacity point is also all are summarized here in point by point. Okay, so this is about PSVT. Okay, next question. A male of 78 years old with hypertension is presented with new onset of mild left hemiparesis and atrial fibrillation. So hypertension, (78-year-old), hypertension, mild left hemiparesis, atrial fibrillation. On ECG findings, on taking history, the patient reveals an antihypertensives can control the hypertension. As a physician, what you can do? warfarin, permanent pacemaker, aspirin, close observation. So the answer is warfarin. Now, aspirin can easily be given to any stroke patients, but it will be sufficient alone. It will be sufficient alone in case of stroke patient. But in this particular patient, ECG is showing showing atrial fibrillation. Atrial fibrillation is found in ECG. So there is a need of anticoagulation therapy before giving aspirin. Very important. If any stroke patient, we can go for aspirin. But if stroke along with atrial fibrillation comes in ECG, then we first give some anticoagulation therapy, anticoagulant. Then we can give aspirin. Then we can give aspirin. So this patient can also be considered as a candidate for medical or electrical cardioversion. And for this, there is a need of pre-treatment with warfarin for 3 weeks. This anticoagulants for 3 weeks, especially warfarin, can be given. And then we go for aspirin. Not along with, actually, then we go for aspirin. Okay. So this is a very special case, and you should keep in mind that this type of questions can come, because if there is stroke, first thing that comes in our mind is aspirin. Aspirin 324 milligram. So it can be given. But in this case, as atrial fibrillation is there, we will not go for aspirin at first. Warfarin, then aspirin. Okay, so next question. A male patient of 61 years old is on aspirin already. Along with that, ACE inhibitors, nitrates, beta blockers for chronic stable angina. According to the patient's history, since 3 days, he is having long-lasting angina every day, even at rest. So ECG result came out to be normal, even troponin I level is normal. As a physician, which of the following management you will choose? So what are the points we can derive from here? First of all, 61 years old. Next, aspirin, ACE inhibitor, nitrates, beta blockers for chronic stable angina. This is the number second. So aspirin, ACE inhibitor, nitrates, and beta blockers are already, the patient is already taking. So according to the history, since 3 days, he is having long-lasting angina every day, even at rest. So angina every day, even at rest. This is the third point. ECG is normal. Troponin I is normal. So ECG and troponin I both are normal. So as a doctor, as a physician, which of the following management you can choose? Increase the dose of the long-lasting nitrates and no need to admit him. Admit him and heparin should be started. Admit him and observe for rise of cardiac biomarkers. Admit him and start thrombolysis. And the answer is heparin should be started. Obviously, admit him and heparin should be started. Now let's see why. In this case, what happens? The patient is known case of chronic stable angina.